Hi, my name is Jeff Houck, and the title of this talk is What Does It Mean to be Psychologically Informed in Physical Therapy? I've divided this talk into 4 parts. The first part is where are we at? The second part is listening to patients. What kinds of things have we learned? The third part is about communication skills and the recent study that we've just completed. And the fourth part is based on a paper that really combines the physical and the psychological. So getting physical and getting personal. So we've seen studies now coming out that patients with musculoskeletal problems don't just present with physical function and pain. They also routinely experience things like symptoms like fatigue, depression, anxiety, self-efficacy problems, and social problems. And this is mainly exposed with outcome measures. And this is a study that we performed at George Fox University in Oregon. And we can look at how these different scales or outcome measures combine to predict somebody's health status, known as a patient acceptable symptom state. And we look at this, really, you would think, well, some combination of these, like maybe depression trumps anxiety, or physical function trumps pain and fatigue, and we don't really need all 7 of these scales to explain a patient's health status. But when we did the statistics and looked at this, really, you couldn't exclude any of these to improve the prediction of a patient's health status. This really reinforced thought leaders in PT, like Peter O'Sullivan in pain, and this is one of his diagrams of how the different factors influence a pain experience. And you can see it has all of these different factors, and that's really consistent with the study that we just showed you and other studies that we've done, is that really it's difficult to reduce patient complaints to one key feature, because if any one of those problems like fatigue or self-efficacy is dominating their thinking or their personal experience, that would affect their health state equally as like physical function or pain. So we know that patients have these kind of complex problems, and we know that at some point they might have an acute problem that then converts to a chronic problem. And so this is our current state of thinking relative to psychologically informed physical therapy, is to prevent this acute to chronic conversion and just address patients better in the acute phase. So this is from a recent paper by the group from Duke, and they put in the actual content of psychologically informed physical therapy intervention varies, may be best thought of as a framework for therapists that integrate contextual, behavioral, and physical treatments. And they use this 5R kind of model to kind of think about the components that psychologically informed physical therapy might include. And that includes realization, which is patient-centered communication, pain modulation or relief, pain coping skills or regulation of their thought processes, active exercise and activity, so reactivation, re-engaging in their lives, and then praising the patient, some type of reinforcement. So these are some of the cornerstones that have been mentioned in the literature. Now, in the same paper, which is from 2021, the group from Duke points out that explanatory trials that include highly trained, controlled implementation of psychologically informed practice in low back pain are successful. So they show better outcomes than not using a psychologically informed approach. However, pragmatic trials that try to scale the approach generally show less good outcomes. And across diagnosis, if we just look at pragmatic data, which I would say that outcome data qualifies that way, we can look at articles that we've done, and I'll show you some of those, and then an article by Fritz. But it's really reinforced by other articles as well that suggests if we look at our outcomes in PT using pragmatic data, it's good but not great. And let me give you an example. So, and this is across all different diagnoses. So we have 1,850 patients in this article by Fritz with MSK problems, and using region-specific PROs, patient-reported outcomes. We can look at their improvement by an MCID, and we can see that the range varies from like 53 to 75%. So good but not great. We definitely have room to improve the achieving an MCID outcome for these patients or sending them on to some other place for care. And similarly, this is data from the George Fox University Community Clinic that we just published. And you can kind of see this is using 4 different scales: pain, physical function, fatigue, and self-efficacy, and before and after a patient visit. And what we're showing here is that if they have lower health state to begin with, they do better than if they're high functioning. So we do better with patients who are sicker than patients who have like less problems. And so we can kind of see that here. And essentially pain interference, they're getting better by 0.7 standard deviation, which is a pretty big change on a promise outcome. Physical function is about the same here, fatigue and self-efficacy, but those benefits are only really seen in patients who are worse off to begin with. So the worse they are, the better our outcomes are. And this is helpful for like focusing our care or noting where to improve. So these practical outcomes kind of suggest to us that we could do better, and the explanatory outcomes for low back pain at least suggest that a psychologically informed approach may be a pathway to be more effective with more patients. So what about if we listen directly to patients, or some data that is about how we listen to patients? And so this paper has been widely cited about physical therapists, how they stigmatize or feel unprepared to treat people with low back pain. And it was published in 2015, so I think our awareness of this in PT is really heightened. And I think, I'm kind of personally, I'm proud of the response of physical therapists to articles like this. But in this article, it really showed that PTs with this biomedical-centric approach to patients really had a difficult time even recognizing psychological and social impacts on pain. They had a tendency to stigmatize patients and then feel better prepared to work with mechanical pain problems versus psychosocial influences on pain, and then also questioned whether psychosocial factors were part of their practice. And this is another paper by Bruner and the Peter O'Sullivan's group, and they were looking at whether therapists could predict just with their own assessments. And I think this is important because we all feel like we connect with patients and we want to connect with patients. That's a central theme in most of the students I train and therapists I know. And this asks the question, can those skills that therapists that are experienced have developed, or new therapists want to have, can they help us see these psychological factors, or do we need training to do that? And so in this particular study, the way they tested that is they used the Start Back tool, and they asked the question, how well can therapists guess, just based on their own interview styles, whether a patient is low, medium, or high risk for chronicity using the Start Back tool. And essentially, therapists' judgments of risk of persistent symptoms, do they match the Start Back tool risk categories? And they only matched 41% of the time. And so essentially, you would do better guessing than you would using the skills that the therapist employed. So part of that's not so surprising for me anyway, when you look at the complexity of psychological assessment and communication skills. We all kind of feel like we're good at it, but I think the reality may be different. And I'm just going to play some quotes from students that I've had that I've asked to listen to patients and listen to patients' stories. And these are 3 quotes I captured from patient stories that students had elicited. So this is a person 9 years after a tendon rupture.
Hey, Bill. I'm Joe. Nice to meet you. So it sounds like that you're able to do a lot of things that you were able to do before the injury. are there any things that, you're not able to do?
I don't play indoor soccer. I basically, if like cutting or stuff like that, there's certain things that I'm just like, maybe I just have like an innate fear about now. And it's like, man, because I'm like getting older. And so, yeah. And so, I mean, I think I could probably go out and run around and play indoor soccer, but I just like don't. I mean, I do go out and I try to exercise like 6 days a week. And so 3 of those days are my cardio days. So I'll go out. I hate running. I'll go out and I'll walk 3 miles and everything else because that's nice. Only last year I was running. But the problem is every time I'm running, I'm thinking about stopping running. I'm not really enjoying it. So yeah, so I mean, I can run, I can do everything else. I just don't want to just do like the cutting and the moving and stuff like that I used to do. And then skiing wise, maybe I feel a little better about it because my foot's in a boot. And my ankles supported. But yeah, I think it's more. I think I can do it. I mean, because like they said, it's going to heal stronger than it was. But I think it's just like some sort of innate fear.
So kind of going back, so you mentioned all the things you stopped seems to be the cutting and kind of like really quick explosive movements possibly on that leg. Is that due to the fear of it potentially injuring again? Or is it just because you're just not interested like we're discussing with running?
Oh, that's a good question too. It's because of the fear.
So a patient 9 years after their injury that still holds a strong fear of re-injury.
Well, I had breast cancer 11 years ago, stage 4, involving lymph nodes. And so I started on chemotherapy that was extremely toxic. And one of the meds that they put me on was Taxotere. And it caused a drug reaction in my body. And it caused nerve endings to become burned and damaged. So not only do I not breathe well, I also have nerve damage across my chest and under my arms that I'm on medication for, which is methadone. And so getting used to being on narcotics every day for a long period of time also takes a toll on a person's well-being, body, psyche, social, but you get used to it because it's better than hurting and you learn to function. So it's easy to keep a positive attitude when you don't have pain and you can breathe and you find that you actually become yourself all over again. You're not a victim, you're not a patient of pain or something to that matter. You're just like everyone else. You know what I'm saying? There's nothing different in taking that than taking diabetes medication or blood pressure medication. It's what I need to do. So
a person who takes narcotics to be themselves all over again and sees it as similar to taking blood pressure medicine.
Yeah. So kind of going off of that, how would you, so it's affected your physical health in the sense where you were saying overuse injury where you've kind of had to modify, take it day by day, can't play as much. What about your emotional health?
Yeah, I mean, it was a bummer, I'll tell you. It never got to the point where I was depressed, but it was, certainly something that mentally motivated me to want to rehab, and rather just not like, woe is me, this sucks, what am I going to do? But, there are things you can do. I mean, you can, first of all, you have to rest and do everything, to kind of, and then, I just followed the PT and the, orthopedic doctor's recommendations. I had cortisone shot in my right shoulder. The cortisone shot in my elbow really, really helped. And then after that, kind of baby steps with weights and PT and bands and all this other stuff. So it did, I think more than anything, the mental health aspect was that you didn't feel completely helpless because there were definitely things you could do to, and I think, yeah, it was just it was motivating because I didn't want this to be like a ending, an injury where it was like, okay, now I can't play at all. So,
So a patient with many different elbow, upper extremity kind of problems related to sports that's managing it with PT, chiropractor, injections, and having difficulty. So I'd ask you all to kind of reflect on just the few studies we cited and then some of the dialogue that we heard, and ask yourself, do you have the communication skills to dive into helping these patients sort out how physical activity, physical impairment restoration, and beliefs and attitudes might change toward their health status? And essentially the studies show that, of the two approaches kind of available, like a provider-centered or patient-centered approach, a provider-centered approach, it's biomedical, so we're focusing on disease status, structures that need to be restored or protected, and then biological determinants like that are predictors of prognosis, and then also directing care based on PT or other kind of provider-based focus. So, protecting the joint from re-injury, or protecting a knee OA, or focusing on a diagnosis, versus a patient-centered approach includes not just biomedical things, but also psychosocial things, so beliefs and attitudes of the patient, showing consideration for what the patient feels like is important, not just if they have a muscle imbalance that the patient may not even know about and may not really care, or their level of strength and fitness. We may want to optimize that, but they may not want to, for good reasons. So respecting their autonomy, and then also including in the session with them, not just physical health, but also psycho and social factors that may be important to the patient. And then finally, letting the patient really be the driver of what kind of treatment they get, how hard to push, and when to push. And so these are real differences between like a provider-centered approach and a patient-centered approach. And essentially in this particular study that was looking at these two kinds of approaches and studying communication skills in patients, what they found is that the PTs use structured, practitioner-controlled, so provider-centered. However, they moderated that style with the responsive style of communication. And so what they meant was that physical therapists attended to their patients' needs through caring and communicative touch. So empathy is the way I kind of connect with that statement. And they used casual conversation, though, and friendly banter to break up the biomedical focus. So the question I would have for you is, instead of using banter and biomedical focus, what if you had better communication skills that could help you dive deeper into some of these problems we've been listening to and kind of thinking about in the first part of this presentation? And in agreement with that is this idea of Therapeutic Alliance, which has been defined in this particular paper as a relational process at play in treatment that can act in combination with or independent of specific interventions. So it's really a separate kind of thing we do with patients, is to try to connect with them and understand how their attitudes and beliefs are affecting their recovery. And the essential elements stated in this paper are goal setting that's really from the patient. So that's, again, that piece of the patient-centered approach that gives the patient control, and agreement on tasks to get to those goals, so that's really clear to the patient so they can be engaged in their care. And then this idea of a bond, so some connection with the patient so there's trust developed. And from this same study, they have quotes from patients who did improve for care and patients who did not. And so just read this quote with me and consider like what kinds of pieces of the Therapeutic Alliance are evident in this particular quote. So Now I know what is good for me and what is not. The physical therapist has taught me a lot about my own body and about my pain. Now I feel much safer and I know my back. So we can certainly see that there's a bond. The therapist taught them something, and what I thought was also remarkable about this particular statement is really there's very little about pain, where a lot of people who kind of have MSK problems, the focus seems to be about pain. That's kind of what brings them in. But notice at the end of care here, the person's really talking about being safe and knowing their back, but there is no comment about pain, which is interesting, right? And now this one who didn't improve, we could maybe see what's missing from the Therapeutic Alliance here. I only went once. I do not think the physical therapist knew how to help me with my problems. I don't think he or she realized what my problem is, because I don't have very much pain or pain all the time. And so here we see there's no trust really developed, and an over-focus on something that wasn't really the patient's issue. So the idea of goals and tasks to get there is missing, and also the bond is missing. So, as we're pressed for time in the clinic and trying to meet patient needs, we really are in this decision of how much of our time and provider focus to kind of sort out the biomedical priorities for that patient, and then also, address psychosocial factors. And so it's not an easy task, and so how to do this best is a real balancing act. Now, one of the things that I do want to just challenge, because most people would say what's a barrier to implementing a real patient-centered approach, and most people would say time is a factor. This particular study comes from GI patients, and with doctors, and they looked at 440 video recorded consultations with doctors and patients, and then they asked them about their patient experience, and they tried to see if it related to the length of time that the practitioner spent with the patient. And so I'm just going to read this out loud. So an analysis of 440 video recorded consultations found no association between the patient's experience and consultation length. And patients sometimes reported good experiences from very short consultations. So what this, kind of suggests is that maybe we feel better with spending more time with patients, but really the quality of the communication, the effectiveness of the strategy may be more important to the Therapeutic Alliance, the bonding, the trust development, and the understanding of where the patient's at, than the amount of time we spend with them. So thinking along these lines, about a year ago, we recruited 2 psychology interns and 21 therapists from the Oregon area and from 6 different clinical sites. And the therapists, or the psychology interns, went to the encounters, patient encounters, and observed them and scored them on the patient-centered observation form to determine what communication skills they were using. We also gave them a questionnaire about their beliefs, not about pain, but about their beliefs about the influence of psychosocial factors on disease. So meniscus tissue damage and neck pain, but not just neck pain, a disc herniation. So the idea of does psychosocial factors affect the patient's disease, not just their pain experience. And the correlation between the communication skills they used and their attitudes and beliefs about the ability of psychosocial factors to influence healing in a person was quite high. So the more likely the stronger their beliefs were that psychosocial factors influence actual healing in the person, the more likely they were to use psychosocial communication skills. So what skills were those? So I'm showing you here skills that PTs not just endorsed, but successfully implemented during these encounters. So I think you'll agree that this is consistent with your practices. PT students and clinicians routinely use, communication skills that are consistent with good rapport, good eye contact, warm greetings, acknowledging all the people in the room, using humor and non-medical kind of interactions to ease patients and bond with them. They also are good at being consistent with recognizing nonverbal and verbal signs of empathy to patients. So they're showing concern for patients and using continuer phrases and repeating content that patients give them so that they know that the patient's concerns are, and demonstrating curiosity, intent, so that the sessions don't seem rushed. So there's this sense that they have the therapist's attention, right? But when it came time to power sharing or really engaging patients, amongst the 10 categories that we assessed, this one kind of illustrates the kinds of communication skills PT did not really use. And so it had to do with co-creating a plan and shared decision making. And so sometimes options were discussed with patients, and this is about 60% of the encounters. And then they would propose a follow-up plan, and I think about half the time that it was really clear what the plan was going to be on the next visit. But all of these other skills were used less than 20% or less of the time, and they include like asking patients about their confidence in executing the plan, what the barriers are to follow a plan, adjusting the plan to the barriers, asking for what patients would prefer. They would like to do the exercise set 1 or exercise set 2. This idea of giving choice to patients really was not endorsed in either thought or communication skills that were observed during the therapist patient encounters. Also, a good opportunity for education. So therapists are routinely endorse education, as they did in this trial, but I'm not showing you that data here, but largely endorsed and used during the visit. There was no real check to see if the education landed. In other words, if the patients had actually taken in the intent of the therapists when they were doing the education. And so how would this occur? You'd ask not just if they have questions, because that's a good thing to do, resolve confusion, but also to ask them to give a summary back or a teach back so that you heard what the patient really took in from that educational module. So you would be something like, okay, can you help me understand what you are thinking now that we've kind of gone through, how the relationship between x-rays and knee osteoarthritis. What's in your head now about and thinking about the importance of that? And listening to the patient reflect back what you thought you had taught them. And so this was widely not used in really any encounters. So these are opportunities to kind of expand our communication skills and connection or bond with patients. Now, something else that's an opportunity for us is motivational interviewing skills. Motivational interviewing skills are considered like a basic counseling skill for psychologists and many health professionals, and they're widely taught in PT programs and continuing education courses. And so the key skills that are taught are open-ended questions, reflections, and summaries. And we tracked that for all 46 encounters. And we can kind of see here is that the open-ended questions were widely endorsed and used. On average 4 times in a half an hour encounter, and in one encounter it was somebody used 16 open-ended questions. Now on the flip side, reflective statements and summaries were in 50% of the encounters, which you see here 24 of 46 and 23 of 46, they were never used. And on average, if somebody used a reflective statement or summary, it was about 1 time and at most 4 for both of those techniques. So another opportunity to expand skills. And this is a critical observation, because what we know is that open-ended questions invite the patient to explain and take a long time in terms of getting out what their stories are, right? And so these are non-directed, non-focused questions. It's up to the patient to kind of fill in the story. And when we use reflective statements and summaries, they're about focusing the narrative or focusing the communication and on getting to a deeper level of understanding about what the patient said, right? And so the reflective statements help us with bonds. They help us focus the communications. So they're going to make the interactions shorter and take less time. Summaries also do the same thing. They help us form bonds. They kind of wrap up a story and a narrative concisely, and so they're going to make the interactions shorter. And open-ended questions invite more understanding and a deeper kind of look at what the patient's explaining. So these take more time. So part of the reason, at least for these encounters, that would explain why therapists feel like they need more time to be psychosocial is because they rely way too much on open-ended questions and need communication skills that help them focus and wrap up or summarize a patient's point of view. So our findings really suggest that physical therapists endorse the intent of patient-centered care, i.e. the beliefs that we assessed, however, lack some of the communication skills to implement it. This is really agreed on by the new article from Duke, where they looked at this discrepancy between explanatory studies and the transference of those studies to a scaled pragmatic approach. They found that there was a breakdown in the skills that they needed the therapist to have to implement psychologically informed physical therapy. So where are you in terms of kind of implementing a communication style that could handle all these different types of psychosocial issues that patients have, the can of worms, and are you feeling confident, or you still feel like you need to kind of develop some skills? So the last kind of piece is more of a strategy. So we talked about skills. So this is this idea of getting physical and getting personal. So this is a recent paper from 2020 that listened to patients' narratives about what helped them successfully recover from trauma. And a key theme is that they needed not just to recover their physical health, but they also needed to recover their self or their identity. So, if they're a strong person or they're a resilient person, they needed to recover that resilience and that sense of strength, right? And so it was really a body and soul type of recovery, not just physical. So the way that this was expressed in the article was that the patient's view was they wanted to recover both their body and their self, and that had to do with two questions. Who am I, and how do I fit into this world? So if I have a spinal cord injury now, well, now I'm no longer an able-bodied person, so now I'm a spinal cord injured person. If I have low back pain, I'm no longer kind of an invincible person. I now have, a person with low back pain. So who am I address this question of identity, and how do they fit into this world given their new identity? How now what's their role? They had to redefine what was a priority for them. The second piece that was important for recovery was their level of engagement. And so if the therapy is too aggressive, right, then they find the challenge of it is too much, and so it's threatening. But if the physical challenges that we put in front of patients are at the right level, and we meet that challenge with reinforcing psychological beliefs about how good it is to push themselves physically, we combine those two, then they can feel safe doing things that really push their bodies. But if we don't combine the psychology with pushing their bodies, the patients may perceive it as a threat, and then they won't participate in care as much. So what's necessary for this is autonomy, understanding beliefs and building self-efficacy, and allowing patients to explore their bodies and their abilities rather than dictating every single thing that they do for a successful recovery. And then finally, the idea of recovery, it was really connected to this positive self, like their beliefs and their ability to control their activities and kind of future physical challenges, and that kind of made them more engaged, and they set goals on their own. They self-initiated their own treatments, and then if they had a negative self, they were disengaged and they perceived the outcomes as less good because they weren't in control. So I hope that we've started to answer this question of what does it mean to be psychologically informed. And I think it starts with your attitudes and beliefs about disease and not just pain. Do you believe that psychosocial factors can influence healing? The second piece is, do you have the communication skills that match those beliefs, that you can now endorse and not just think about giving the patient control, but actually trust them to take control and give them options and autonomy for the recovery. And the last piece, I think, is, do you have a well-developed strategy or framework that helps you implement the communication skills when you think the patient needs them, or refer the patient out when you think they need to be referred? Thank you. Appreciate your time and listening.